Good morning once again. It's a very intricate problem. We are always to balance our life in every aspect of life. And same is the story with the coronary artery intervention, especially when do PCI. There are two main important risks. One is the ischemic risk and the other is the bleeding risk. And how we ought to balance between the two, I've got nothing to declare. And as I have said that there are two events, ischemic events and bleeding events, and right combination of antithrombotic agents at the right dose of duration to reduce the ischemic events as much as possible at a minimal cost of bleeding. And the sweet spot to find out is always a challenge. And as you know, on the left side, the two main drugs for antiplatelet activity, aspirin and P2Y12 inhibitors, are being used for quite a long time. And there are certain conditions where the PCI is to be done even in cases of bleeding or those patients who are on oral anticoagulation. So the balancing act must be much more stringent on those cases. There are a few facets of the subject. One is the high ischemic risk conditions where the stent type matters, location or the anatomy of the coronary arteries matter, and also the various risk groups like syntax, PCI compass, then IVAS or the other imaging guided risk scorings. Then on the other hand is the bleeding. The bleeding, as I told, that there can be pre-existing bleeding conditions or de novo bleeding occurring after interventions. Both are high risk and prone for bleeding. Both the conditions are high risk patients for bleeding. Now, understanding the complexities of CAD is crucial as it involves managing DAPT effectively to mitigate both bleeding and ischemic risk, ensuring optimal patient outcomes after PCI. These are certain conditions where there can be anatomical changes in the form of bifurcation, then CTO, and when we use the atherectomy, then when we use the PCI after bypass graft. And in all these cases, complex cases, risk of adverse events after 12 months of randomization, there is a high chance of bleeding, as has been shown in the particular slide on the left hand side. The Forrester's chart is showing that the event is more. And this is one case of mine where the triple balloon casing was done. Obviously, it was a very high risk patient. Now, there are standard strategy for chronic coronary syndrome, and here the standard care is aspirin is the class 1 indication and prasugrel or ticagrelor, and when it is not tolerated or when it is not available, then only clopidogrel as class 1 indication, and then it should be continued for 6 months. And in high bleeding risk patients, aspirin plus P2Y12 inhibitor is to be continued for 1 month in CCS. It is a class 2B indication, and in case of again high bleeding risk, the first one was very high bleeding risk and the second one is high bleeding risk, where it should be continued or may be continued for 3 months. But in standard cases, again, one may continue for 12 months or so if there is high or moderate risk of ischemia but no high bleeding risk. So same as aspirin plus P2Y2 inhibitor. Now the default strategy of management of ACS without oral anticoagulation is that you ought to continue the aspirin plus the P2Y12 inhibitor as a class 1 indication for up to 1 month, and after that you ought to continue aspirin and P2Y12 inhibitor up to 12 months if there is no high bleeding risk. After the 12 months, actually, there are two strategies. One is that you can continue the aspirin as a class 1 indication, and you may try with P2Y inhibitor as a class 2B recommendation. Now, if there is OSE, associated with ACS, OSE means oral anticoagulation, the default strategy is again for this particular condition is class 1 indication aspirin plus ticagrelor, and it is to be continued for around 7 days to 1 month. And after the 1 month, you are to continue with only single antiplatelet agent as a class 2A recommendation. And after 12 months, you are to continue only with the oral anticoagulation. These are as per the various trials that have been shown in Entrust-AF, PCI, Pioneer, Reduel, etc. And in very high ischemic risk and no HBR, only P2Y12 inhibitor is a class 2A recommendation. And moderate risk cases with no high bleeding risk, you may try with the P2Y12 inhibitor. This is the summary of whatever I have said over the past few slides. But the most important point is that this yo-yo movement has continued for over decades. Sometime recommendations were done for short DAPT for 3 to 6 months. Sometime it went for long DAPT for more than 12 months. And in that way, in the latest period, again in 2025, as I'll show you, that the recommendation, the suggestion has been made for short-term duration. But having said this, I'll emphasize that one should individualize the approach in managing the cases of ACS or even CCS with a high bleeding risk or no high bleeding risk. These are some of the trials shaping the field of this therapy, short-term therapy or long-term therapy. Twilight, Tycho, Stop, DAPT, Global Leaders, Augustus, Dual SCS. The Dual SCS Neo Mindset target fast, tailored, cheap studies. These are the studies which have been shown in 2025, and these are the studies which actually demonstrate either in the form of de-escalation or escalation strategies. Now, these are few trials, Dual SCS trial, which showed that following an acute market infarction has the potential for better survival and lower bleeding rates compared with 12 months of DAPT. So they suggested the duration for 3 months of DAPT. In Neo Mindset, it's an ultra short DAPT therapy for 4 days, and after that, if it is continued for 12 months in ACS patients, it failed to demonstrate non-inferiority of P2Y12 inhibitor. So it failed to demonstrate non-inferiority. Same way in target fast study, P2Y12 inhibitor monotherapy was non-inferior to continued DAPT. And they suggested that the 1 month of DAPT without complications, it also resulted in lower incidence of bleeding events. Same way, the tailored CHIP trial also showed no beneficial effect in patients with high risk anatomical or clinical characteristics undergoing complex PCI. This aquatic trial, which was presented in ESC 25 just 1 month back, the aquatic trial provided crucial data for patients on OSE who are more than 6 months out from PCI. The trial found that adding aspirin to an OSE regimen worsened clinical outcomes, driven by a higher risk of cardiovascular death and also increased major bleeding. This strongly supports the practice of dropping aspirin in patients on chronic OSE, especially after the initial high-risk period following PCI has passed. So the key suggestions for 25, mind it, this is not a recommendation, was abbreviated DAPT 1 to 3 months, and followed by that P2Y12 inhibitor monotherapy as the default strategy for a large majority of patients undergoing PCI, particularly those meeting high bleeding risk criteria. Now, what we can do, how can we improve the outcome? There are certain data-driven decision making, and here comes the role of the AI, and here the various trials like AI, ACS, DAPT AI, they have validated that the AI has got a role in precision medicine or precision cardiology to determine the various kind of therapeutic measures. And 30% fewer major bleeds versus standard risk were found in AISAS, and 22% lower MACE was found in DAPT-AI. So these are some of the facets of various risk, whether high bleeding, high ischemic, low bleeding, high ischemic, high bleeding, and so on and so forth. But current recommendation is that it should be tailored for the DAPT for more than 12 months in high risk, high ischemic risk patients. Now, there are certain changes in ethnicity, especially in the East Asian countries, where there is a paradox. There is more chance of bleeding, and especially the intercerebral hemorrhage and GI bleeding. And this particular group might be benefited with tailoring the medicines, and balancing the act is very, very crucial in this group of patients. And there are two facets. One in the Eastern Asia is the high bleeding risk. On the other end, in the South Asia, like India and all, the DAPT resistance, especially the clopidogrel resistance, is a great problem. So you are to choose the the antiplatelet agents as well. The same way, we can improve the outcomes by more liberal use of intercoronary imaging. Use of transradial techniques versus transfemoral techniques also change the scenario. Use of bioresorbable polymer coated stent with abbreviated DAPT duration versus the prolonged one has also changed the scenario. And intensity and duration of antiplatelet agents tailored by physicians improved the prognosis. As I already told, that genetic or genomic studies can be used for personalized approach for incorporating the therapeutic measure. And what are the features directing towards the antiplatelet therapy? There are certain PAR inhibitors, targeted therapies, especially the nanotechnology and gene therapy can possibly alter the whole situation. These are certain reversible P2Y2 inhibitors and factor 11 inhibitors like selatogrel, cangrelor, which is already in the market, factor 9, factor 11 inhibitors. They are also being tried in the various scenarios. The bioresorbable stent was questioned a few years back, but again with the modification, they are coming back to the scenario, and they are being used, though the recommendation has not come fully, but they are the future for the taking care of the balancing act, and thereby we can definitely give a precision medicine or precision kind of treatment in this very intricate group of the coronary disease, whether it is chronic coronary syndrome or acute coronary syndrome. Thank you very much for patient hearing.